Hello everyone, my name is Rafael Aponte. I am a medical doctor from the Center for Research and Training in Neurosurgery, CIEN, from Bogota, Colombia, and today I'm going to present you the entitled abstract, an atypical presentation of Suzuki stage 6 Moyamoya disease with patency of the anterior and middle cerebral arteries, a case report. Bilateral internal carotid artery chronic occlusion (BICACO) is a rare entity. Etiologies varies according to the occluded internal carotid artery (ICA) segments. In the proximal segments, the most frequent cause is atherosclerosis. Moyamoya disease is the most common cause of distal supraclinoid BICACO. BICACO in Moyamoya disease patients appears at the end stage of the pathology, Suzuki stage 6, and usually implicates the disappearance of the anterior ACA and middle MCA's cerebral arteries. We performed a retrospective review of inpatients with cerebrovascular disease on a 4th-level institution in Bogota, Colombia, that presented to the emergency department from January 1st, 2018 to 31st December 2020. We looked for atypical presentations of BICACO, finding the present case. A 56-year-old woman presented to the emergency department due to transient altered mental status after a thunderclap headache. On physical examination, the patient had hypertension, right side hemiparesis, and neck stiffness. Computed tomography of the head showed an intracerebral hematoma in the left basal ganglia, subarachnoid hemorrhage in the sylvian fissures, and a mild line shift. Diagnostic cerebral digital subtraction angiography revealed bilateral occlusion of the supraclinoid segments of both ICA after the emergence of the ophthalmic arteries. The DSA also revealed that the vertebrobasilar system supplied the anterior circulation, including the anterior cerebral arteries, the middle cerebral arteries, through the posterior communicating arteries. On our clinical and diagnostic workup, we ruled out first some etiologies. Agenesis was ruled out at first. On a recent publication by Lee et al., a novel classification system for ICA agenesis was presented. They divided ICA agenesis into 8 types, but only 2 types involved bilateral ICA anomalies. Type C had a bilateral agenesis of the ICAs, but it began from the common carotid artery bifurcation, not our case. And type E had hypoplasia of the anterior circulation rather than agenesis, not our case. As we said before, atherosclerosis is a common cause of proximal ICA occlusion, and no, we did not find any case on the literature that presented BICACO on distal segments caused by atherosclerosis. So we allowed this diagnosis too. As we said, distal BICACO is commonly caused by a Moyamoya disease, and our case was an atypical presentation because we did not find on the DSA the rete mirabilis sign, a pathognomonic sign and a common sign of Moyamoya disease. Medical treatment and periodic imaging were performed, with hematoma resolution and improvement on neurological status. As conclusions, we can say that distal BICACO with anterior cerebral arteries and middle cerebral arteries patency might be an uncommon presentation of Suzuki stage 6 Moyamoya disease. Further studies are required to establish the pathophysiological origin of the persistence of these compensatory changes at the late stages of the disease. Here you can find our references, and please, enjoy the 2021 International Web-Based Neurosurgery Congress. Thank you for watching.